Good afternoon, I am Giacomo Grasselli from Milan, Italy, and I will discuss the evidence supporting the use of ECMO for ARDS. These are my disclosures. And this is the first report of the successful use of ECMO. This was veno-arterial ECMO in a patient with acute respiratory failure. This was a soldier from the Vietnam War, and the report was published in 1972 in the New England Journal of Medicine. After that first case, this first randomized controlled trial on extracorporeal membrane oxygenation in acute respiratory failure was published in JAMA in 1979. As you can see here, 90 patients randomized to VA ECMO versus conventional management. As you can see, there are very low and non-different survival rates. And there are many reasons for the failure of this trial. But the main reason is this, in particular the extremely high risk of bleeding in those patients who received almost 4 liters of blood transfused every day. So it's not very difficult to understand why the NIH trial failed. Then Theodore Kolobov, together with Luciano Gattinoni and Antonio Pesenti, proposed the idea that since oxygen and CO2 are transported through different physiological mechanisms in the body, then they can be managed differently, separately, with the extracorporeal support. So we could use extracorporeal support to manage separately oxygenation and CO2 removal. And again, this is because oxygen and CO2 are transported through different mechanisms. So the oxygen transport is limited by the shape of the oxyhemoglobin dissociation curve, while CO2 transport in the blood is characterized by high content at relatively low partial pressure. So this results in the fact that the extracorporeal support is much more efficient in removing CO2 rather than in improving oxygenation. But also the first randomized trial on the use of extracorporeal CO2 removal, so low flow extracorporeal support, together with intermittent positive pressure ventilation, was negative. This was a trial performed in 40 patients, again with a low overall survival, and also here a high incidence of bleeding complications. So after the publication of this trial, ECMO and extracorporeal CO2 removal were abandoned in most countries and in most centers, and only very few ECMO lovers continued to perform ECMO. But then, in the recent years, some factors have contributed to resuscitate the ECMO support, in particular the technical improvements. We now have better cannulation techniques, we have more biocompatible circuits, we use very sophisticated and very efficient pumps, and very efficient membrane lungs. Then we have developed the concept of ventilator-induced lung injury, so the idea that with the extracorporeal support we can facilitate protective or ultra-protective ventilation. There is the health organization, which is a very big organization that has a large registry and provides guidelines and support for research. And then there was the pandemic flu. And as we all know, after the pandemic flu in 2009, the number of ECMO centers raised incredibly in the world. And this is, as you can see, the actual situation before 2020. There are a very high number of ECMO centers in the world, and an steadily increasing number of cases treated every year. And then we have the evidence from two large randomized controlled trials. The first trial is the Caesar trial that was published by Jill Speak in Lancet in 2009. So they included 180 patients with severe but reversible acute respiratory failure. These patients were randomized to conventional treatment or referral to consideration for ECMO support. What is very important is that out of 90 patients who were randomized to transport to an ECMO centers, only 75% of them actually received ECMO. And the primary outcome of the study was the incidence of death or severe disability at 6 months. And as you can see here, patients who were transferred to center with ECMO capability had a much lower risk of death or severe disability at 6 months. So this is universally considered the first randomized controlled trials showing an advantage for ECMO over conventional treatment. Strictly speaking, it's not really ECMO per se, but it's rather the transfer of the patients to a very experienced center with ECMO capability. And then second trial is the EOLIA trial published by Alain Combe in the New England Journal of Medicine in 2018. They randomized 240 patients with ARDS ventilated for less than 7 days with one of 3 criteria: PF ratio below 50 for more than 3 hours, PF ratio below 80 for more than 6 hours, or pH below 725 with a PaCO2 above 60 millimeters of mercury for at least 6 hours. These patients were randomized to ECMO or conventional ventilation, and crossover was allowed to ECMO in patients with refractory hypoxemia. And you can see here the Kaplan-Meier curves. The ECMO group has an 11% lower risk of death, but this was not, strictly speaking, statistically significant. You can see there the P value was 0.07, and so the conclusion of the paper in the New England Journal of Medicine was that ECMO showed no significant benefit in terms of survival as compared to a strategy of conventional mechanical ventilation. But of course, this is questionable because an 11% absolute risk difference is certainly clinically relevant. And so we probably don't think that the EOLIA is really negative. Well, first of all, the trial was stopped early for low recruitment. Second, 35 controls were crossed over to ECMO. Again, the 11% absolute difference in mortality is certainly not irrelevant. And among the secondary endpoint, the risk of treatment failure at 60 days that was defined as as combination of death or crossover to ECMO was strongly in favor of ECMO. And then Ewan Golliger proposed a post-hoc Bayesian analysis of the EOLIA trial, and that demonstrated that ECMO was associated with a posterior probability of a mortality benefit ranging from 88 and 99%, and that the probability of an absolute risk mortality reduction of 2% with ECMO is higher than 98%. So the Bayesian analysis is a little bit different from the conventional statistical analysis, but shows, I would say, quite strongly that ECMO is associated with a significant improvement in survival. And based on the meta-analysis of the Caesar trial and of the EOLIA trial, in the recent guidelines from ESICM that I had the honor to co-chair together with Luigi Camparotta and Caroline Calfi, there was a dedicated domain on ECMO support, and the PICO question was: in adult patients with severe ARDS or COVID-19, does VV-ECMO compared with conventional protective ventilation reduce mortality? And we were able, based on the meta-analysis of these two large trials, to issue a strong recommendation a strong recommendation in favor of the use of ECMO in patients meeting the EOLIA trial eligibility criteria. So this was a strong recommendation in favor, and immediately after these guidelines, also the ATS, the American Thoracic Society, published its own guidelines, and also the ATS guidelines have a recommendation in favor of the use of ECMO as a rescue treatment for refractory hypoxemia. And so I would say that this is a very reasonable flow chart for patients with acute respiratory distress syndrome that is refractory to conventional treatment. I would say that it's very important that every patient with a PF ratio below 150 is given a trial of prone positioning before going to ECMO. And if prone positioning fails, if one of the EOLIA criteria are met and the patient has no clear contraindication to ECMO, then there is a clear recommendation for centralization of this patient and eventual ECMO treatment. And I remind you that the inclusion criteria of the EOLIA trial were a PF ratio below 80 for at least 6 hours, despite an optimized ventilatory strategy, a PF ratio below 50 for at least 3 hours, and a PF ratio below and the pH, below 7.25 with PCO2 of above 60 millimeters of mercury for at least 6 hours. And I would also like to point out that in the secondary analysis of the EOLIA trial, it was shown that the subgroup of patients who had the highest benefit were those with respiratory acidosis and PF ratio below 80, while the subgroup of patients with the more severe hypoxemia, so PF ratio below 50, had exactly the same and very high mortality when ECMO was compared with conventional treatment. So apparently ECMO is more efficient, is more effective when the patients have not extremely severe hypoxemia. And finally, which are the future perspectives? Well, we are moving towards an earlier application of the extracorporeal respiratory support, eventually also extracorporeal CO2 removal in patients with less severe hypoxemia, so even in patients with moderate ARDS, to allow ultra-protective ventilation and minimize the risk of ventilator-induced lung injury. We are still trying to understand which is the best way to ventilate the patient during ECMO, and there are reports that maybe we could associate a near apneic oxygenation with ECMO, so to almost stop ventilation to reduce again the risk of ventilation-induced lung injury. And also the third point is to understand whether ECMO can be an alternative to conventional ventilation. So if we could use ECMO to extubate the patient or to avoid intubation and to keep them awake with the extracorporeal support, granting the respiratory support to the patient, avoiding the negative consequences of intubation and prolonged invasive mechanical ventilation. With this, I thank you very much for your attention, and thanks for the invitation to participate in this important event. Thank you.